Mental health treatment plans are the most audited document in behavioral health, and a vague goal is the fastest route to a denied authorization. It is the primary artifact payers use to authorize every service your team bills. Get it wrong and the denial follows automatically. Whether you are writing a treatment plan for depression, for anxiety, for substance abuse, or adjustment disorder, the structure is the same and the stakes are equally high. Components, SMART objectives, ICD-10 codes, payer authorization, and the EHR features that keep every chart audit ready. A mental health treatment plan is the written clinical contract between provider and client. A complete plan documents the diagnosis, problems, treatment goals and objectives, evidence-based interventions, and how progress will be measured. For clinicians, it is the care roadmap. For payers, it is the medical necessity evidence. For accreditors, the audit trail. A plan without measurable objectives is a liability. Payers look for measurable objectives. Vague goals like improve mood are audit flags. They cannot demonstrate progress across a 90-day review cycle. CARF and the Joint Commission require a client signature on every plan and each revision. An unsigned plan is one of the most common survey findings. A behavioral health treatment plan missing any of these 6 components is considered incomplete and may trigger a denial or an audit finding. Let us walk through all 6. Step 1. A specific diagnosis with a matching ICD-10 CM code. The code on the plan anchors every subsequent progress note and claim form. Avoid unspecified codes like F32.9. Payers flag heavy use as weak documentation. Support the diagnosis with a scored instrument at intake. That baseline becomes your progress benchmark at every 30, 60, and 90-day review. Step 2. A prioritized problem list. Identify and prioritize issues by severity, impact on daily functioning, and what the client says matters most. A listed problem with no corresponding goal is a plan deficiency. Step 3. Broad, client-centered treatment goals. Goals are broad, long-term outcomes. Most plans carry 2 to 4, each tied directly to a presenting problem. Client involvement in goal setting increases buy-in and motivation, and satisfies CARF and Joint Commission participation requirements. Step 4. SMART objectives, where most plans succeed or fail a payer review. Objectives must be specific, measurable, achievable, relevant, and time-bound, giving the utilization reviewer quantitative evidence. Client will reduce anxiety symptoms by 50% within 12 weeks, as measured by the GAD-7 assessment. Step 5. Evidence-based interventions tied to each objective. Name the modality, who delivers it, and how often. Generic entries like individual therapy without a specified approach are a common audit deficiency. CBT for cognitive distortions, DBT for emotional regulation, EMDR or CPT for trauma, mindfulness and psychoeducation for skill building. Step 6. Review dates, signatures, and discharge criteria. Build review dates into the plan aligned to the payer's authorization window. 30 or 60 days for higher levels of care, 90 days for routine outpatient. Every revision needs client and clinician signatures with credentials and date. A missing aftercare plan is a frequent accreditation audit finding. Document it. The ICD-10 code on the plan anchors every note, every claim, and every authorization. Major depressive disorder. F32.0 mild, F32.1 moderate, F32.2 severe. Recurrent episodes use F33.x. F41.1 is the most common outpatient anxiety code. Avoid F41.9 when a specific code fits. F43.23 covers mixed anxiety and depressed mood, common for shorter outpatient episodes. F10 through F19 cover substance use disorders. The subtype documents remission status, critical for ASAM placement. Measurement-based care is the backbone of a payer-defensible plan, and the assessment work is billable. CPT 96127 covers brief emotional and behavioral assessment with scoring. Covered by most commercial and Medicare payers. GAD-7, or PHQ-9, at each review, produces the trend line that demonstrates progress, or flags a stall requiring revision. A plan misaligned with the authorization chain causes denials. Before services start, the payer wants the diagnosis, level of care, and a draft plan. Gaps here trigger costly denials. At each checkpoint, the reviewer compares the plan to recent notes. Stale goals are the leading cause of denied continued stay requests. Behave Health's EHR is designed to support compliant treatment planning from first draft to discharge. Select the active diagnosis. DSM-5 aligned objectives populate automatically. A defensible starting point, not a blank page. The AI assistant suggests measurable, time-bound goal language, clinician reviews and signs. Every note links to an active plan goal, the evidence trail payers need. A strong treatment plan protects your revenue, satisfies your payers, and guides better clinical care. See how Behave Health connects treatment planning to documentation, authorization, and billing in one workflow. Book a 20-minute demo at behavehealth.com and see treatment planning built into your EHR.